The following is the final part of a 5-part series wherein the medical intervention gender-affirming surgery is discussed from a clinical perspective. The featured physicians each have decades of medical experience with an intimate knowledge of both medicine and the medical industry. In this final video, the politicization and normalization of transgender healthcare will be discussed. The intention of this series is to take an objective, scientific look at these intersex operations. As such, the content at times will be explicit, and the viewer should take precaution and use discretion when viewing.
Welcome to the Gold Report, where we inspire you to be 10% more courageous. I'm so glad you're here. Please like, share, and subscribe so you never miss an episode. Today, we welcome back Dr. Melanie Crites-Bachert for our final episode in our 5-part series on medical mutilation. We'll begin after this short break.
Somebody comes to us when they are the most vulnerable. We have an obligation to our patients to tell the truth as we learned it and to not politicize it. We are performing surgeries on these children that have neither the capacity to make these life-changing decisions nor the wisdom, and the only people benefiting is the medical industrial complex, because the more surgeries that are done, the more money it is made.
Whether you're talking about an 8-year-old or an 11-year-old or a 14-year-old, I don't see how you can actually derive informed consent.
We all know that we can't be getting true informed consent.
I didn't really realize, but there was a sickness that had been afflicting the profession for a long time.
Our medical industry has objectively been compromised in more ways than one.
You become familiar with the sound a mother makes when you tell her that her child is dead.
Our show today will conclude our 5-part series on medical mutilation, often referred to as gender reassignment surgery. We're pleased to welcome back our guest, Dr. Melanie Crites-Bachert, an expert in her field of medicine, and there's no one more qualified to speak on the topic of medical mutilation. She received her medical degree from the West Virginia School of Osteopathic Medicine in 2003 and completed residency in urological surgery at the University of Medicine and Dentistry in New Jersey in 2009. She then received fellowship training to specialize in female pelvic medicine, voiding dysfunction, and pelvic reconstructive surgery from the Cleveland Clinic, Florida. Dr. Crites-Bachert is considered an expert at treating urinary and fecal incontinence, sacral neuromodulation, and has a higher than national average success rate of 93%. She became a nationally recognized consultant and proctor for sacral neuromodulation therapy as a result. Her research and implant protocol is patent pending and has established national precedent for the successful implantation of a sacral neuromodulator. Additionally, Dr. Crites-Bachert is highly trained and skilled at performing pelvic organ prolapse surgery with and without mesh, and she's very skilled at surgically treating complications from previous mesh surgeries. She maintained an active role in research and tracked her own personal outcomes with pelvic reconstructive procedures. She's published long-term data results from her own patient population for treating urinary incontinence and pelvic organ prolapse as a private practice surgeon. Today, we will discuss the political and legal environments that either promote or prohibit the medical mutilation of children. We want to emphasize that although Dr. Crites-Bachert is highly qualified, she has chosen not to perform medical mutilation surgeries. There are many voices currently speaking about this topic from different perspectives. There are resources available that weigh the pros and cons. The focus of our series is to provide the necessary medical information about these procedures, information that is completely absent in public discourse, and we will be exposing the brutal physical reality of medical mutilation. So let's dive right in. Welcome back to the show, Dr. Crites-Bachert. So we've had very interesting conversations so far, and today we're going to talk about kind of the legal and political backdrop that in which we find ourselves in 2024 vis-a-vis medical mutilation surgeries. And this is a sensitive subject. It's a very politicized subject. People get censored and slimed for talking about the subject. So I want to give you the opportunity to just, speak directly to the public and say, why are you speaking out on this and where you come from? Because you know that there's going to just be haters out there who say, oh, she hates trans people. But of course, I know that's not the case. So I just want to give you an opportunity to address that.
Look, politics has absolutely no role in medicine. Surgery is surgery. Outcomes are outcomes. Sometimes that's pretty, sometimes that's not. And my job as a clinician, as a surgeon, as a doctor, are to present the facts from my experience, from what I've seen. And surgery is not always 100%. Surgery does not always turn out the way that we want it to. So I want to be very, very clear. It has nothing to do with politics. These are the facts as I have experienced them. And when we are speaking about children, I have a very, very sensitive spot in my heart for children. My dad was always, always an advocate for children. And he always used to say to me, you've got to take care of the little fellers. Being from West Virginia, that was something, his way of saying we have to be responsible for each other and for the children. So I am here today, and thank you for asking me to do and share my expertise, because this is something close to my heart, and to share truth, as I said, as I know it, as I've experienced it. Sometimes the truth isn't always pretty.
As a surgeon specifically trained in pelvic reconstruction, when did you first start noticing this politicization? I mean, where we can't even agree on the terminology. Is this something that you've seen throughout your career? Is this more of a new development?
In various degrees throughout my career. When I entered into private practice, the whole big controversy was pelvic mesh, transvaginal mesh, and that it was had fallen out of favor because there were so many people and so many providers, surgeons doing these procedures. And there were a lot of complications as a result. And so transvaginal mesh was actually taken off of the market. Some companies, for instance, American Medical Systems, had a transvaginal mesh product that was taken off the market, and AMS, has since closed. But at that point in time, there was a big movement that transvaginal mesh was bad and nobody should be using it. And then there became very strict guidelines for the use of transvaginal mesh. So I'm a vaginal mesh surgeon. I'm very skilled at treating pelvic organ prolapse with transvaginal mesh and complications that should arise. So the tide has kind of softened and turned a little bit, in that now anybody using mesh, anybody doing a procedure with mesh, needs to be specifically trained to do that, and to be specifically trained to handle the complications should they arise. And so these are the general guidelines that are being followed now. So I feel like at that point in time in 2011, when that started, or when that was getting going, that's when we kind of started seeing some things in medicine start happening, where there were big blanket statements being made. But one of the things that I found at that point in time was that transvaginal mesh is not bad. What was happening is that it was being marketed to every surgeon. Well, not every surgeon should be doing that sort of procedure, but they were making it very easy and very user-friendly. So every surgeon was doing that. And if you're not specifically trained to do that, of course you're going to have complications. And I feel like that's kind of where we've come with these particular surgeries now that we're talking about with medical mutilation. It's now crossed over, not just for adults, but it's now crossed over to children. It's like, well, we now see that, this is a big thing with adults. Now let's include children in this.
So to flesh out the example that you're giving, so 10, 15 years ago, they're having this product that they're selling, transvaginal mesh, and it was having a lot of complications. So that sort of got no.
Mm-hmm.
But you're saying really in the right hands, transvaginal mesh is a good product, but it shouldn't be in the wrong hands.
Correct.
So that would be the analogy here, is that really only the right surgeons should be performing the procedures. And then we'll both say, and only for the right patients.
Correct.
Because now there's like a patient demand.
You
to
have
do
to have
something.
the right doctor. You have to have the right patient.
Right. Because it's not as though patients are coming up demanding urological surgery with transvaginal mesh
Correct.
who don't need it.
Correct.
But we wonder if there's a demand, an artificial demand from people to get these surgeries.
Correct. Got
it. Now I understand that. So again, I have trouble with the word politicization of trans issues is making for what I think are some like nonsensical observations. So to put it into political terms, there are blue states that are touting women's rights, but they think nothing of trouncing women's rights in sports when they're up against men who've been surgically transformed in their appearance to appear as women. And we see that more in blue states. And it's as a girl who grew up with women's sports finally being prioritized to the point that now you can watch women's sports and people enjoy women's sports and, all the advantages that come with, being funded. Quite frankly, you needed a whole generation of girls playing sports to grow up before people took it that seriously. People will watch, for example, women's NBA basketball now. They never watched women play basketball in the 80s and 90s. So these rights that we women have fought for a long time, to see them just abrogated so quickly by people is frustrating. From your point of view, does constructing a penis, removing breasts, testosterone therapy, and mastectomy, does that equip women to compete against men in sports? Again, taking off a penis or putting on breasts, right? In what way does this equalize the playing field between the two genders?
It doesn't equalize anything except physical appearance. You cannot change chromosomes. And you can change physical appearance. But there are always certain characteristics that biological men have and biological females have. So the only equalization that we have is the outward appearance.
Right. It's really upsetting, I think, to a lot of people when we see biological men taking trophies, financial awards, and places of position and honor that are now being deprived to young girls. And I guess I'm just happy that I'm not raising young girls, because it's heartbreaking. Are you aware of any successful surgeries that allow men to menstruate or bear children?
No.
Right. Anyway, earlier in the series, we showed a clip of a physician testifying in support of the standard of care being backed by data, but couldn't present any such data when questioned during her testimony, right? So we had this, the doctor. So she said, this is the standard of care, but she couldn't actually provide what that was. So not only do we have to deal with all these politicized or woke doctors, but we have to deal with advocates with no medical training to push the medical studies through a certain bias, the LGBTQ bias. Like, it's not pure medical research anymore. And I was hoping you had time to review the article below so I could ask your thoughts on what doctors and patients are up against in protecting our youth today from the trans agenda. Maybe these are kind of harsh words, and I have empathy really for all human beings. I think all human beings have the same inalienable human rights, under God. But the trans agenda, the political trans agenda, seems to be threatening the safety of other non-trans youth, for example, like in the area of sports or the area of, even in the area of mental health. I think of children who are sad or depressed or confused, who can easily be swayed into this medical morass that we've been discussing. So I'm going to post an article that is coming from a trans advocate who does not have medical training. And I feel as though this information then becomes politicized, and anybody who opposes this is then kind of censored, shamed, or threatened. I think that physicians have to be the bulwark. Like, I think we have to be the stopgap measure against which, where uninformed people come to us and then we have to stop. But how optimistic are you that physicians are going to provide that bulwark for unrealistic expectations from patients?
I'm very disheartened, honestly. I'm very disheartened with my profession because, as we've seen with COVID, um, and this is probably going to be very controversial, but there was no room in the medical profession for dissenting views. It was always follow the science, follow the science. But science is ever evolving. That is science. What we knew 10 years ago about a particular subject may not be what we know now as things have evolved, as studies have come out. So, as we've seen, providers have been very leery about saying, "Hey, there are other things to explore, other things that we need to study in this realm." So I'm very disheartened. I don't think
Right.
that physicians now are giving that stopgap and telling a patient, "Look, this may not be in your best interest. Let's take a look at this. Let's take a look at that." I was always very open with my patients. If they came to me and they were insisting that they needed a surgery for urinary incontinence, for instance, if that's not what was the most appropriate thing for them, I would say, "No, that's not
Right.
that. Let's try these things. Let's look at these things because this may not be
Right.
in your best interest."
So you hit the heart. That's the heart of my question is, again, people know that my father was a doctor, so I've experienced medicine really from birth onward, and I've just seen how medicine and doctors have changed radically. I grew up knowing, and the first part of my career was really the doctor, had the training and the knowledge and really the unbiased perspective of,
Mhm.
the only thing we were biased towards was in the patient's interest. So patients all the time would come to us with things that were unrealistic or fanciful, and you'd
Mhm.
be like, "No, that's not going to work. That's not even relevant." And then the patient would accept it because they knew you weren't biased and they didn't have any information. Now we're advertising to patients all the time. Patients come in thinking that they know what they're talking about, and they actually don't mostly know what they're talking about.
Mhm.
But the pressure on doctors to just either financially, time pressures, or socially to conform to
Mhm.
whatever's the popular view at the moment, I just think has been overwhelming. And
Mhm.
I just see doctors collapsing overwhelmingly and giving in to whatever is the patient's desire, which is not appropriate when it's a test or medicine, but is wildly inappropriate if we're talking about life altering surgery that chops off body parts.
Absolutely.
So I'm like you. I'm pretty discouraged. And I don't, for any doctors who are watching this, you have an obligation, you have an ethical oath. You swore some ethical oath when you graduated medical school to do no harm. It always starts with do no harm. We
Mhm.
doctors can do a lot of harm. So yeah. So we're just going to move on. So I do feel, I'm a person who became publicly known after during 2020 for speaking out against a popular narrative on the COVID materials. So I do know the hate that is slung a person's way if they swim against the tide. They go against the grouping. So I do feel that physicians who call out medical mutilation for what it is are being labeled as anti-trans,
Mhm.
and they're being pitted against their colleagues. They're being pitted against hospitals and organizations that they've been part of because those organizations have become very politicized. So you have a lot of physicians who are just kind of afraid of being canceled or censored
Mhm.
if they speak out against this. Um, in this article, for example, the Pediatric Gender Clinic at Children's Hospital in Los Angeles conducted a study on, quote, chest reconstruction and dysphoria in transgender minors and concluded that professional guidelines and clinical practice should consider patients with chest surgery based on individual need rather than chronological age. So, wow. I mean, I guess they're saying 9-year-olds? I don't even understand that. A pediatric gender clinic that probably has significant financial benefit from making this recommendation, so that individual need, not the age of consent, should shape the professional guidelines and clinical practices. I mean, I guess that there's no bottom age under which they think this would be okay. By the way, I want to reference people back to when I was in medical school and took classes on transgender. It was absolutely prohibited to think of doing this for young people. In fact, the research still shows, more current research shows, that we really don't know about young children. Like there are a lot more young children who say things that could be interpreted as gender dysphoria than adolescents or young adults or adults. It keeps going down, as you age. So we have a pediatric gender clinic that is really saying, well, there's really no bottom number. Wow. Have you experienced any such stigma attached to your practice, given that you're trained to do these procedures and have chosen not to do it? Like, is this the kind of thing that if you go to a conference that you're sort of looked at a little bit askance? Like, what is that like for a urological surgeon who chooses not to do these procedures?
Well, we all have our fields of expertise. If you do pelvic reconstruction for incontinence like I do, you tend to go to the conferences that that are specifically related to your field. So if somebody chooses to do these particular procedures, they'll go to those meetings. But what I will tell you is in recent years, these sorts of issues have started infiltrating the meetings that I go to. There's at least 3-4 lectures on transgender population or reconstructive, and so it is infiltrating. It is moving over and infiltrating all of these sorts educating environments.
That's a good observation, because really, I guess what it's doing on the one hand, you could say, oh, we're educating doctors on these new issues. On the other hand, I think they're just normalizing something that shouldn't be normalized. The reason I say that is there always was a time and a space for subspecialty interests.
Mm-hmm.
I mean, transgender science and procedures has been around long before I went to medical school. So it existed, but that was your subspecialty and you sought it out. But now they're putting that out into the mainstream, which is giving you, a general surgeon, the idea that this is very mainstream and normalized.
Mm-hmm.
Right. That's actually really odd, because this is not a common problem. No data suggests this is common. So you've practiced in many places in the country. Are you aware of the political winds in certain states in which you practice? Like if you're practicing in the Pacific Northwest, or if you're practicing in the Northeast or in the South, do you notice differences in how people talk about these
I have
issues?
noticed very distinct differences in my practice. I often say, with my personal background, I'm originally from West Virginia. There's a certain mindset that we have in the South. There's a certain mindset that we have, meaning cultural things. And I feel like it is the same thing with medicine. There are particular pockets where to go if you're seeking out particular things. If you are looking for instance, somebody to treat prostate surgery or prostate cancer, there tend to be pockets, for instance, in New York and Chicago, that have those doctors who specialize, and they have big centers for that. So those areas, in medicine, we just know if you're looking for a particular type of surgery or particular cancer care, for instance, you go to different places.
So same with the transgender, you're saying?
Yes.
Yeah. So there's certainly advocates that are pushing what they're calling gender affirming care. Does it seem to you that physicians who oppose gender affirming care or medical mutilation have the ability to express opposing opinions and data without repercussions?
It's very difficult. And, as a doctor who has gone against the grain, I have personally experienced backlash for speaking out against different things, and speaking out, for instance, much like yourself during COVID. I was a doctor who was analyzing everything as it came out. And so much like this, I was always very slow to adopt the latest and greatest thing when it came to surgery. When slings, for instance, for urinary incontinence came out, I was using slings, but then they changed to these mini slings and they were touting this was the latest and greatest thing, minimally invasive surgery. I was very, very skeptical of that because I wanted to see the data of how effective this was, and was this truly the best thing for my patients? So I've always been a very slow adopter of things because I want to see what the fallout is going to be before I, in good conscience, tell my patient this is or this is not the best thing for you. So it does get very difficult being, as you know, a physician who doesn't go along with popular opinion and may be a slow adopter of things. When you're somebody who is supposed to be with the times and these doctors are, these other providers are referring their patients to you.
So as doctors, I think we're temperamentally suited to being more risk averse than average. And then as you go through medical school and residency training, you really learn to be cautious and, if anything, become more risk averse because you've seen the 1 in 50 that has the bad result or the 1 in 30 that has the bad result. So all of my career, it was natural for a physician to be slow to adopt. Now, there's always an outlier, innovators who are coming forward with new things, which is great. But everyday people and everyday doctors wanted to be slow. They didn't want to be the first one. But now we have a situation where you've got zealous advocates pushing and doctors who are going to be punished for speaking out, so they become more meek. I think this is very dangerous. I can't think of, I'm sure there are other examples. Can you think of anywhere you had zealous advocacy really influencing and overruling a doctor's tendency to be cautious and risk averse? There probably are other examples, but it's hard to think of one, right? I think it's a dangerous combination.
It certainly is, because ultimately at the end of the day, you are responsible for that patient's care. And as a surgeon, the last thing that you want to do is harm that patient, because if you are truly a responsible surgeon, a responsible provider, that patient is yours. You take ownership. You are ultimately responsible for somebody's life.
Right.
And as physicians, I think we truly get so wrapped up in the day-to-day medicine that we forget we are responsible for somebody's life.
Right.
And there are times that we are the ones that make the decision for that person's life.
Right. So it's offensive to me, actually, that a person of a particular political, sociological, cultural belief, I'm not talking about the patient, but a person who's got a specific advocacy position, is minimizing the expertise and knowledge that a surgeon might have, who's saying, listen, if you go down this path, you're going to have lots of complications and you probably are not going to get the result you want. But over here, you've got a cheerleader, rah, 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 rah for it, who has never seen the inside of an OR, has never seen the surgical complications, and has never seen the failure rates.
Mm-hmm.
Or maybe, I could speculate, has experienced the failure rates and wants to share the misery with other people. Maybe they're bitter. I don't know. But they shouldn't be given equal weight in the patient's mind with someone like yourself who has done the surgery, seen the complications, and taken actual responsibility for that human being. I think that's what is very upsetting to me as a doctor, is the recklessness with which advocates are speaking about multiple surgeries with multiple risk factors.
I would completely agree. And, I would also add to that, when it comes to medicine, ultimately, it is not the lobbyists, it is not the activists. It comes down between the doctor and the patient. It comes down to that relationship, the doctor, the patient. And if the patient is a minor, then whomever is acting as guardian, parent, guardian for that minor. Medicine is such a personal thing, and specifically surgery. It is such a personal thing that it has to be very intentional. It has to be very intentional. I feel like everything about life should be intentional. How we live, how we interact should be very intentional. Our words should be very intentional. Medicine is that space where things have to be even more intentional. And as we've previously spoken, going through a process like this was very intentional. It addressed mind, body, spirit. It came down to the doctor and the patient had to be very intentional about what they wanted and their research. And in a lot of ways, that intentionality has been left out of medicine now, that patients are coming in saying, well, I want this. And if a doctor bucks that, well, then the patient's going to go to the next doctor who will just do whatever they want to do. And intentionality has been left out of medicine. And when you're talking about no surgery is minor, that's what people don't realize. No surgery is minor. And I've even fallen into the trap of, oh, this is just a scope. It's going to be a quick procedure, in my mind as I'm planning my day. It's just a scope of the bladder. It's going to be a quick procedure. But then you go into those situations that are very humbling, where you find something that you don't anticipate. So all of these things have to be anticipated, especially when we're talking about surgeries like this.
That was fantastic. I completely agree that intentionality is lost, and it's being lost in favor of zealous advocacy on one side and the other side being too meek about the actual risks.
And there used to be a time where a doctor's opinion was gold. That was, being a doctor and being responsible for somebody's life was an honor. And that was the deepest, most honorable thing that you could do. And now doctors are being pushed aside, that our opinions seemingly don't hold the weight that they used to anymore.
I have to share with you, because my dad was a doctor, and he told me when pharmaceutical advertising became legalized in America, we are still only one of 2 nations where pharmaceutical advertising is legal. I believe the other nation is New Zealand. Basically, direct to consumer advertising of medications is rampant here. We all see it. But my father told me that was going to destroy medicine, and I was a young girl, and I remember he was so emphatic. He wasn't vague about it. He wasn't like, well, it's not going to be great. He's like, it will destroy medicine. I've never forgotten that. I think I was about 10 years old. And what surprised me is his certainty that it wouldn't just hurt patients and doctors, but it would destroy it. How prescient was he? Because that has actually led us here. If a doctor's opinion isn't more important than the commercial from a company that is selling you a product, it's not more important, because we doctors have allowed this as a society. So why should we be surprised that, if a commercial can persuade a patient, why shouldn't a zealous advocate or a Facebook group persuade a patient? Sure, we've really sold ourselves short. We've sold out. So I do think this is really, in a very broad way, comes back to the fact that medicine has just become very commercialized. It's very commercialized. So anyway, Dr. Crites-Bachert, it's been an absolute pleasure and really an honor.
Thank you. It has been for me as well. Thank you.
To just give the world an insight into what you know from having your hands on patients and what you know to be true. We hope to share this information widely with lots and lots of people. And if you're watching this, and if you are a physician, an organization, or an entity that wants to help out or jump more into this space, please write to us at info@aflds.org. If you're an individual struggling on these issues or have more questions about this, please come to our website, aflds.org, for more information. We've posted lists of resources that may be helpful for you. And to find this was part 5, our finale on our 5-part series on medical mutilation. To find all 5, please come to the Gold Report. Please subscribe, and you'll be able to find all 5 of the series. And thank you so much for joining us on the Gold Report, where we encourage you to be 10% more courageous. Please like, share, and subscribe so you never miss an episode. See you next time.